Assalamu alaikum. I welcome you all for this session today on type 2 diabetes patients, patient-centric practicalities with oral semaglutide in Ramadan. As many of you are familiar, I'm professor of medicine and consultant endocrinologist at Medcare Hospital, Dubai, affiliated with Mohammed bin Rashid University and also my parent country, Aga Khan University, and founder and former president of Pakistan Endocrine Society. These are my disclosures. Today we are going to talk about the oral semaglutide, and as this session is focusing on upcoming Ramadan, how can we make it easy for our patients to continue with a safe fasting journey during the coming Ramadan. We all know the medical rationale for oral semaglutide is because the timely treatment of type 2 diabetes is needed, as we all know, to reduce the risk of complications. But usually the clinical inertia on the part of patients, physician, is one of the reasons that many of the patients still do not achieve current A1C targets. The newer options available now for the type 2 diabetes have made life easy, and the GLP-1 receptor agonists are one of them, or in fact one of the top ones, because they not only provide effective glycemic control, but they also provide weight reduction with a low risk of hypoglycemia and improvement in risk factor for atherosclerotic cardiovascular disease. So many of us over the years have learned that with low risk of hypoglycemia and weight reduction, the management of type 2 diabetes is rewarding, the patient motivation is achieved, but one of the strongest barriers has always been the injection or the needle phobia, or as the patients usually feel, this is the last resort. With the tremendous success in terms of efficacy and the safety of GLP-1 receptor agonist, especially once weekly semaglutide, now we need an oral GLP-1 because many of our patients are still not ready to go for injectable. Availability of an oral GLP-1 receptor agonist will lead to initiation of GLP-1 receptor agonist therapy earlier in the course of diabetes, and it will improve the acceptance and adherence for patients compared with injectable formulations. We have always been facing the challenge for insulin and other peptide molecules that how can make it orally available. And I always believed, like many of us, that it will be very difficult. But thankfully, we have been successful now. The challenges have been that the peptide molecules have got poor absorption in the stomach due to enzymatic degradation as a result of low pH, acidic pH, proteolytic enzymes, and the limited permeability across the gastrointestinal epithelium for the peptides. So it leads to low oral bioavailability. We are all familiar with semaglutide, and all of us have used semaglutide injectable in our patient population. And in general, we are all more than satisfied for that. But to make it orally available so that it can be absorbed, it has been designed to be co-formulated with SNAC, which is a sodium N-amino caprylate, a small fatty acid derivative that promotes absorption across the gastric epithelium. It counteracts for the effects which I mentioned earlier. It generates an increase in pH along the proximity of the tablet, so the acidic pH is avoided, and then it promotes absorption across the gastric epithelium and achieves adequate oral bioavailability. To study the impact of oral semaglutide, a very robust pioneer program was established, and as you can see, it is across the entire continuum of a patient with type 2 diabetes. It has been compared with placebo versus the commonly used oral agents, SGLT2 inhibitors, DPP4 inhibitors, and other injectables as well. In across all these pioneer studies, we can see that the two important outcomes, A1C and body weight, were studied, and we found that the mean baseline A1C and then reduction in A1C across all was significantly better in the group which was given oral semaglutide compared to the comparators. And here you can see this blue bar, which represents oral semaglutide, 14 milligram, in all aspects, especially with the most commonly used oral agents for type 2 diabetes nowadays, empagliflozin and sitagliptin. It was very good in terms of the A1C reduction and much superior to the comparator agent. Similarly, the most important other component we are worried about in our patients with type 2 diabetes is body weight. And across all the pioneer program studies, we again see that it was much better reduction, which was significant across the comparators, again, whether it's placebo or empagliflozin or sitagliptin, although it did very well compared even to liraglutide in the patients as well. Besides the beneficial effects on the glycemic control and weight, we see here that oral semaglutide versus placebo also reduced the fasting triglyceride and VLDL cholesterol. It reduced the systolic blood pressure and reduced the inflammation markers of high sensitivity CRP, which are important for the atherosclerotic cardiovascular disease prevention or management. Across the studies, it was seen that in terms of the serious adverse event, oral semaglutide was well tolerated and safety was established across the program. And as you can see here, compared to insulin, compared to in the placebo, in the renal groups, other injectables, orals, across all these studies, the blue bar is not going above the comparators. It was most of the time, and in fact, always across the continuum, it always below. So the serious adverse events were almost less across the whole spectrum compared to the comparators. Then the second important part in terms of severe or blood glucose confirmed symptomatic hypoglycemia, again we can see that in the 14 milligram, the blue bar group, across all the studies, as we know from the mechanism of action, is glucose dependent insulin secretion and the glucagon suppression. So symptomatic hypoglycemia or severe hypoglycemia was less than comparators and the placebo, which makes it easy, especially as we are talking about in terms of Ramadan fasting as well. For the cardiovascular safety, a trial was established with Pioneer 6, in which 3,000 plus patients were randomized either to oral semaglutide or placebo, and they were followed up. The mean A1C was 8.2%, the duration was 14.9%, and the average age was 66 years. The primary endpoint was time to first occurrence of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. As you can see, the two lines separate, and the first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke was less in the oral semaglutide compared to placebo. So from the p-value, a non-inferiority was established in the events compared to placebo. When we see the components of the primary endpoint, again we can see that the all-cause death was reduced in the oral semaglutide, and the non-fatal stroke and cardiovascular death were also reduced in the oral semaglutide form. As we know that oral semaglutide is same as injectable semaglutide, so both of them were compared in this analysis with the placebo, and then when we compared the data for that, you can see that there was 24% reduction in the risk for non-fatal MI, non-fatal stroke, and cardiovascular death, as well as the other components were also seen. Now let's come to the practical use of oral semaglutide. As we all know, it is not easy, but it has been lucky for all of us that now we are able to give to our patient an oral peptide. So we have to make some efforts as we do in all patients. And I think if patient is well educated, they make use the best use of this oral molecule, which will work in terms of optimal glycemic control with low risk of hypoglycemia and weight management as well. I think they will listen to us. So because of the absorption feasibility in the oral semaglutide, it should be taken in a fasting state. So we recommend to our patient wake up fasting and take semaglutide tablet with up to half a glass of water. Just simple wait at least 30 minutes before eating, drinking, or taking any other oral medications. And as for all the GLP-1s nowadays, we have got a formulation for dose escalation is recommended to mitigate the GI side effects. So you start with 3 milligram, then go to 7 milligram, and based on the individual treatment needs, either you can continue with that or you can increase to 14 milligram once daily for further improvement in glycemic control. Now, as the Ramadan is coming and many of our patients for the first time will be going through using the oral semaglutide in Ramadan, a group of experts has developed a consensus for recommendations for titration and administration of oral semaglutide for the treatment of type 2 diabetes during Ramadan. The recommendations are such that we should initiate oral semaglutide at least 6 to 8 weeks prior to the month of Ramadan to reach an effective dose at least 7 milligram, which is common in terms of the guidelines from the DAR and other platform that GLP-1 receptor agonists, because of their nausea and vomiting, cannot be initiated just before Ramadan or during Ramadan. We should avoid up titration or dose escalation within 2 to 4 weeks pre-Ramadan and during Ramadan. Considering that the fasting state is required for the optimal absorption and the efficacy of oral semaglutide, it should be discussed and agreed with the patient with clear written instruction that it is preferred that oral semaglutide is taken when breaking the fast. This is not in the morning, although we always break the fast in the morning. But in Ramadan, we break our fast at iftar. So it should be taken at iftar and then you take the part in the Maghrib prayer and then eat and according to oral semaglutide dosing instruction. Oral semaglutide should be administered on an empty stomach, same as before told, with no more than 120 ml of pure water. Wait for 30 minutes after administering before eating, drinking, or taking other medication. Although the oral semaglutide dosing instructions are recommended to be implemented as above, individual and local differences we'll discuss in the next slide may be observed in some patients. Infrequent deviations once or twice per week, as happens in Ramadan for many of our patients because of the timing or when they are not home, etc., it will not have a large impact on the semaglutide absorption, but persistent deviations may lead to changes. So preferred oral semaglutide dosing schedule during Ramadan is to be taken when breaking the fast after sunset and then wait 30 minutes, say your Maghrib prayer, and then eat afterwards. Well picturized here. There are some deviations which are expected, as I mentioned. There are some who could take pre-suhoor fasting period is less than 6 hours, then you can take it at suhoor, but it will be affecting the absorption and absorption could be reduced. If you take more water because you are just breaking your fast and we are used to take more water instead of 120 ml, be a bit patient because it will again affect the absorption and it may be reduced. Taking a small amount of food, dates, etc. again, possible, but we understand it could affect the absorption and alter the post-dose waiting time that instead of 30 minutes, you take 20 minutes or 10 minutes because you are breaking your fast, you may be just rushing for it. So it is important to highlight and make sure that our patient understand for the good Ramadan experience in which they go through the fasting experience very well without any problems of hypoglycemia, but at the same time, not running into hyperglycemia and affect end of the month or after the next visit for their A1C and glycemic target, it is recommended that they should try their best to continue as recommended for the oral semaglutide during Ramadan. Let's discuss the patient case. For example, Mr. Anas has had type 2 diabetes for 9 years. His age is 56 years. He comes to you regularly and his BMI has raised from 30 to 30.4 to 32 in the last 9 months. A1C has also gone from 7.4% to 8.1% in the last 9 months, which is a common scenario for many of our patients. They have got comorbidities, hypertension, hyperlipidemia, and background retinopathy. He is currently on medication like Ramipril, atorvastatin, and for diabetes management type 2, he is on metformin 1 gram twice a day after meals, glimepiride 4 milligram in the morning and 2 milligram in the evening. He has a history of ex-smoker, sedentary lifestyle, and mother had type 2 diabetes and she died at the age of 65 years from a stroke. As expected, your concern and your patient concerns are same. He's worried about increasing A1C levels and increasing weight. He's worried about the dosing schedule of multiple medications. He has heard about that when the A1C control is not good, he may have to switch over to the injectable or it may be insulin as well. And this will increase the risk of diabetes complication. So we discussed the treatment strategy for this patient. And as usual, as we say, nowadays, we empower the patient and individualize the treatment. So we give him the options by giving the educated notion that what are the benefits and disadvantages for the various options available. For all of us, it could be adding an SGLT2 inhibitor, adding a DPP4 inhibitor, adding a GLP-1 receptor agonist, or adding basal insulin. The patient has already shown concerns. In the last slide, I mentioned that he's not ready to start injectable. So although injectable GLP-1 receptor agonist could be a good option considering the outcome data for all the GLP-1 receptors now abolish, and it may be easily once a weekly. So now we discuss and we have to choose from oral options first. And data from the Pioneer program discussed today, the patient and the physician, which may be you start oral semaglutide because it is superior to the comparators available in the oral form, SGLT2 inhibitors and DPP4 inhibitor. So oral semaglutide was acceptable to the patient as a first option. After 3 months on the oral semaglutide now, 7 milligram, so you start with 3 milligram and move on to 7 milligram. After 3 months, you see that the BMI again from 32 to 30.2, A1C from 8.1% to 7.4% in 3 months. It is one of my patients. And the patient is now still on metformin, but the dose of glimepiride has reduced from 4+2 to 4 milligram. And it's very likely that in due course, and especially if he goes to 14 milligram, the sulfonylurea glimepiride may be reduced further. The patient was very happy with the results. He feels more motivated and willing to continue. He's happy to increase dose to 14 milligram daily and happy that he managed to do without injection and would like to be more cooperative to avoid and delay insulin for the future. So the take-home message is timely treatment of type 2 diabetes is needed to reduce the risk, and yet many patients do not achieve the target. So we have to be intensifying the treatment as soon as possible. We know that GLP-1 receptor agonists provide effective glycemic control with low risk of hypoglycemia and weight reduction. So an oral GLP-1 like oral semaglutide will lead to early initiation and acceptance of the patients and the good adherence compared with the injectable formulations. Thank you very much.